inpatient treatment center or an IOP program or something like that, and getting on naltrexone might be better for that particular patient. So I think the first part of this thing is trying to help make that decision, help them make that decision, educate them, so that they can, understand, well, should I do this or should I do that? If they choose to be on Suboxone, if they think that's a good route for them, then I can make a call to one of 3 doctors' cell phones. They'll answer it. One of them is a self-pay doctor. One of them takes insurance and TeamCare, because I get all these different calls. I want that person to be seen in a day or two. They got to strike while the iron's hot. And I'm fortunate that can happen. And I just got the TeamCare guy recently. Up until then, I didn't have a lot of referral sources for doctors that took TeamCare as payment for Suboxone, for their services. So that was cool. So I go down to his office in Manchester a couple times a month, and I teach classes down there on recovery while on Suboxone. And then I have another doctor that comes to my office, and so I can call him. He'll get somebody, and if I say, hey, they're withdrawal right now, he'll say send them over and to his office in Nashville down here. So this is really good. To me, this is some potential life-saving stuff that we're able to do. Of course, patients that are on Suboxone get very, very stable. And once they're stable, they're only the Tennessee guidelines, the federal guidelines say that they should have counseling once a month. Once again, that is really, to me, is not individualized enough. I don't think it's a law. Maybe it is that you have to have counseling once a month to get Suboxone. I think TeamCare says that they won't keep you or pay for you unless you're seeing a counselor once a month, whatever. I have things set up with these doctors where I shoot out faxes, counseling verification, so that part of it is covered. I've been doing this for about 7 years now. I got into rooms like this and discussions like this 7 years ago, 6 years ago, 5 years ago. Excuse me, turn this off. And at that time, I was meeting more doctors, and I became a sponge, and I started studying all the clinical guidelines that SAMHSA has, all that stuff, bought all those books, studied all that stuff. I figured if I'm going to be doing this, I want to learn as much about it as I can. Or I want to make sure that I'm doing it the best way I can do that. I tried to get a book about counseling techniques for people that are on Suboxone. What's the best way to counsel? Because it's different. The counseling strategies that you will use with somebody on Suboxone, especially if they're on long-term maintenance, is a lot different. Instead of, if you see somebody and you're seeing them for 2 months every week, or IOP, is a lot different than if you're seeing somebody for 5 years once a month. In a way, it gives you a whole long time to work on a whole lot of different issues. So, you can get into can get into a life coaching kind of thing because they got so much time. What are their issues? And you know what? Some of them don't have any. Some of them just have addiction, and everything else is pretty well. They maybe they're married, they got kids, maybe they got addicted because they had a surgery and they've only been, that sort of thing. You get all different kind of people. You have to be individualized for that. So I went online and tried to find a book about how to counsel these people, and I found one. 5 years ago, there was one book on Amazon.com, so I wrote one. Now there's 2. I wrote a second edition because I learned a whole lot from the time I wrote the first one to the time I wrote the second one. Then I started talking to people in my field, late at. Man, I became the darn black sheep, whatever you want to cast aside. How dare me talk about, using some kind of medication, you're not really clean, and you're just swapping one drug for another, and all this kind of stuff was coming at me. And these are people that I respected. These are people that have been in this field as long as I have. These are one of them is actually helped train me years ago, and I just couldn't believe why they were so locked into not being open-minded to this idea. I have my thoughts of why that might be from their own journey and stuff like that. I didn't let that persuade me, because that's okay if certain people have certain ideas. I can still pick and choose my ideas. So I chose to continue doing what I was doing, and stop arguing with people. To me, the federal government, in general, I think Suboxone is probably a gold standard of opiate disorder treatment. And so I ran with that. That's what I was doing. And I kind of built my own network, my own doctors, my own practice, and that's what I've been doing. I don't really get into debates about it. To me, the debate is over. But I'm a qualified clinical supervisor, so I'm able to train counselors as well. So I have some young people that come to me and they want to become LADACs, and so I make sure that they can see this thing from all sides. But that prompted me to write the second book. Clinician's Guide for Medication-Assisted Treatment. And my hopes here is that people, clinicians that are interested and want to learn the best ways to do this would have sort of a guidebook to help them do it. So I got those two things out there. I'm doing what I'm doing. A project I'm working on right now is I'm trying to get an alternative sentencing for opiate addiction thing going. There's an alternative sentencing for DUI offenders in Christiana, Tennessee. And if you get a DUI, they have classrooms. I teach a class out there. The Prime for Life is out there. You can work it out where you don't have to necessarily go to jail for 48 hours. You could go to this place instead. Well, because I'm a consultant out there, that got my mind into, wow, what if they could do that with opiate addiction? Because what happens now is somebody gets arrested, they're addicted to opiates, they put them in jail, and they go through withdrawal on a hard, cold cement floor in a jail facility for 5, 7, 10 days, however long it takes. They get out of there, and their skin is crawling, and the first thing that they want to do is go, and the overdose rate for people in that situation is 100 times higher than your average addict out on the street. Up in Boston, in Massachusetts, in New England, different places up there, they're experimenting with a lot of different kinds of getting people hooked up with Suboxone, either in jail or when they get out of jail. A good program right away to avoid that kind of thing from happening. I thought and still think it would be a really cool idea to do that in Christiana. We get somebody in there, they wrote bad prescriptions or whatever, they get sentenced or whatever. They can come out there, we could have a doctor see them if they have opiate use disorder. If they wanted to be on Suboxone, they could have that option. If they're already on it, they could stay on it. That's another thing. I've already got that part done. If they're already on Suboxone, they can stay on Suboxone. Because, a lot of DUIs nowadays are not alcohol. A lot of DUIs are opiates or marijuana, quite frankly. And so if they're on Suboxone and they go out there, they can stay on it. They don't do that at the jails. So that's another. So anyway, the owners and stuff at that place have bought in. I have a doctor that would be willing to do that. But now I'm talking to the judges and the legal system here at Rutherford County. And now I ran into another big law. And so, I'm kind of backed off that for a minute. There's only so much time in a day, and I don't have a lot of time to debate or argue about something that I believe is already really effective and saving lives. Having said all of that, coming over here, I thought to myself, I don't want to have to help them make it. I don't want to even be in a position to try to help them make a decision on anything like that, because that's above my pay grade, and I don't want to get into that. I work with pilots. They have a very strict monitoring system. I work with MDs as patients. They have a very strict monitoring system, more so than you guys do. The pilots, man, they got to get psychiatric evaluations and things that are off the charts. But anyway, so I don't know whether they should be allowed to be, I know that pilots, were not allowed to be on antidepressants and stuff not too long ago, and now they can, certain types of it. So, that stuff, I really don't know the answers to those questions, but I have a lot of patients that are doing really well. These are people that own businesses, that make six figures plus, that are just really high-functioning people in the community that are taking low doses of Suboxone, being maintained on it. And I could discuss all you want to about the how-to, how long, how to taper, all of that stuff. I've tapered people off of Suboxone successfully without any problem. People are on long-term maintenance, especially people that have chronic pain issues. So, having said all of that, I forget where I was going with that. Making the decision. I went to a couple of these people that are really upstanding citizens in the community, and I asked them this question I saw here. Oddly enough, I asked them if you were in a hospital, because I've never taken Suboxone. Now, I'm in recovery for 29 years from opiates the first go-round, back in many years ago. But I've never had Suboxone in my body. I don't know what it feels like. So I asked some of these guys, if you were on Suboxone, if your nurse was on Suboxone and you were in the hospital, would you feel confident having them treat you or your wife or anything like that? And it was just an overwhelming, not even thought about it, yes. But, that's just them saying that. And then one of them said, well, I'd rather have them on Suboxone than on Oxycontin. And I thought, that's kind of a bad either or right there. So anyway, I came over here today.